Okay, do you mind if I ask the first question?
Yeah, of course.
Well, is there anything you'd like to share before we get started with questions?
Yeah, so, I am a T-cell researcher, right? I told you that was my conflict of interest, but we use your T-cells too much. That's not good. We all need our T-cells to work, and, these CAR T-cell therapies and bispecifics are amazing, but we can't just keep using those because people will die of infections. That's one of the big things that we see. So really, our non-T-cell therapies are really just as important. And so I want to make sure, I love CAR T-cells, but everything in myeloma is really, really important. There was a paper I wrote a couple years ago on the embarrassment of riches of myeloma because we have so many options. That's a good thing. The more options we have, the better I can treat each of my patients that's coming in. Because again, everybody has different, comorbidities, other medical things, other medications they're taking, medical related stuff, but also coming back to that personal choice and what's really important to you and, what risk are you willing to take versus not. Yes, all of our therapies are fantastic, but all of them have different side effects. And so again, I don't want to increase any symptom burden you already have if I don't need to, and that's a goal of ours, is to decrease your symptom burden. But having all these other options are really, really important. And so some of them are, like our IMiDs, our Revlimids, our Pomalists, they're sort of like a they're in between chemo and immunotherapy, so they can actually improve your immune system and activate it, but they also work through something called cereblon that's within the myeloma cells, and that's how it kills it, right? There's other therapies. So for 1114, that's the one type of myeloma. About 20% of patients will have something called translocation 1114, where we don't have an officially approved treatment yet, but there's a drug called venetoclax that actually goes after that pathway, and we have used it, and there's a lot of other drugs being developed for patients with 1114 because we know how to target it now. We have lots of research going on with other pathways as well, like 1416. We're trying to figure out what in that cell happens when people have these different types of changes that we can actually target. So there's drugs that are targetable that we're also looking at. There's already medications like selinexor that are out there that are oral therapies that actually work in different pathways within myeloma cells that we can use. Blenrep just came out, so belamaf, it was on the market and then came off and now is back again. And it uses BCMA, so that target that we talked about with CAR T, B-cell maturation, but doesn't use your T cells in the same way. It actually is an antibody drug conjugate. So there's a drug, part of it called MMAF, but it's a drug that's conjugated to BCMA, and that's how it actually gets the myeloma cells. And so it really actually it's like targeted drug in that sense, that it uses that BCMA to get to the myeloma. And it's in combination with either Pomalyst or Velcade as to how it's being approved back. So a lot of our patients are excited about being able to get that. There are very few of my patients where I'd say a T-cell therapy is just not the right option. So then that's a great option for them. But there's also patients who relapse after some of our CAR-Ts and bispecifics, and we've been able to use these drugs, and they've done really well with it. And so I think we have, quite a few. I don't know if there's anything else I forgot. Carfilzomib, Velcade, of course. Those are really important in our relapsed refractory. In the end, again, we have so many options, but the question comes down to how do we sequence this, right? So our goal is cure, but until we get there, we got to give you the best survival along with the best quality of life. So each time someone relapses, my question always is, what are the tools I have that I think are going to work, and how am I going to make sure they're not going to cause major side effects for my patients, right? And again, early line, when people are in their first remission or second, I don't like saying the word remission. I'm trying to start saying it now that I have the CAR-T data. I think remission for most people means that they're done, right? And I want that for my patients, but the majority of my patients have to stay on their therapies to keep it controlled. And we're just modifying the dosing to make sure that it's working, but it's also not causing major side effects. So I call it response. So the first time you're in a response, hopefully for many, many years, potentially decades now with our new regimens, my goal is I have this great therapy that I know is going to work for a long time. I have to make sure I don't do something that you either die from because of a bad infection or you get major morbidity from, right? Renal failure or a clot that could actually cause major issues down the road. So our goals are a little bit different. That risk benefit is a little bit different versus when my patients are 6th, 7th line, I need anything that's going to work, and we might take a little bit more risk. So that changes, right, with each line of therapy because of what's left and what we have available. Now, thankfully in myeloma, again, we do so much research that there's always something coming. And I used to say to my patients, I think there's going to be 3 drugs in the next year or so that are coming out. One finally got approved, got a little delayed, but finally got approved, the Blenrep yesterday. And the other 2, hopefully, there's going to be some more coming out in the next year or 2 that have already gone through phase 2 and phase 3 studies as well that we're excited about. So I'll stop there. Any questions? Oh, lots, okay.
Okay, we'll try to take them all and then write them down because we have Q&A at the end also.
I have a very basic question, and it sounds kind of stupid, but what is relapse? Because I know there's different official definitions. I know if you're in a study, relapse is defined a certain way. And and the reason I'm asking is, so I would be in kind of relapse right now, I think. Maybe not. But the reason is so insurance looks for certain things, doctors look for certain things, patients look for certain things. Right. And for instance, I'll say, doctors will say, oh, well, when you're at a 0.5, M protein, then that's official relapse. But now you see certain studies where when you come off MRD negativity, some patients will get treatment just to see. So is there some sort of sliding scale
it is a sliding
thing
scale.
that defines, whether you're actually relapsed or what to look for?
That's a great question. So, we have the IMWG criteria, right? That is what's helped put some context to everything. So that's where if you have an M protein, it has to go up by a certain amount before we call it an official relapse. So we have something called biochemical relapse versus clinical relapse. So clinical relapse, if anyone has new bone lesions or breaks a bone because of myeloma, or they have kidneys that are worsening because of myeloma, or their anemia is getting worse, those are things that we need to treat right away. So that's an absolute for every single patient, right? And those are my patients I wish I knew a couple months before that happened, right? So this is where biochemical relapse comes in. We have patients who are high risk, and then we have patients who are standard risk, and then we have all this in the middle. So this is where I use sort of my history with my patients to say, if this patient got 10 years with their first therapy, they were able to come off maintenance and did really well on observation for a long time, maybe I can watch it a little bit longer. Now, the second I see the biochemical happen, so usually it's an M protein. If it was 0, once it gets to 0.5 or 0.5 to 1, light chains is a little bit different, so we don't have to go into details, but I'll usually do imaging. And if I do imaging and I don't see any active bone lesions, and again, hemoglobin, kidneys are fine, I might wait till they get to 1 on that higher end of that biochemical relapse before we say, let's go ahead and start treatment. Because again, if that patient was off therapy, they're doing really well, they're feeling great, time, right? The time that you don't have to come see me or have to get treatment is important. So we put all that together. Now, if I have a high-risk patient that within 2 years or a year of transplant, they're relapsing with new bone lesions and things are going crazy and I have to find new treatment right away, the next time maybe they were MRD negative and now they're MRD positive, I technically haven't treated anyone just MRD positive yet. We do that in leukemia because of data that shows that. But I do watch those patients really closely. And if I do MRD testing again and again, and it's doubling, and I'm starting to see the M protein going up and the light chains go up, even before they hit that biochemical definition, I might change their treatment because I know that patient's not going to do well if I wait long, right? So this is where that art of medicine really helps when patients are not on trials. Clinical trials are great, but yes, they have these rules. And so sometimes my patients who have high-risk disease on trials, I'm just watching them week by week because as soon as they hit, I want to have a next treatment ready for them so they don't have a bad outcome, right? Versus, again, my patients who have really indolent disease, where even if their numbers come off, they come off study, sometimes I don't treat them because I know they're doing so well. So yes, we have the IMWG criteria, but it really depends on what your disease was like before and how aggressively it's coming back that we're worried about.
Okay, next question. And then we'll try to go back and forth, okay?
Thank you for a great presentation. You sound like you are a great engineer. You said you wanted to be one. I think you already are one. Could you just clarify you said there's 2 CAR-Ts that are approved. Originally, they had to have multiple relapses, but now one of them is approved for the first relapse?
First relapse, second
and
line.
And the second one is
third
the other
relapse.
One? For the third
line, second relapse. because we call the first line the induction treatment if you get a transplant and maintenance.
So second line is
So
the
second
first.
line and third line.
Got it, and that's the first relapse.
And second relapse.
relapse. Okay, and then real quick, I didn't catch the distinction. I mean, I understood from your beautiful explanation how CAR Ts work. I didn't understand how bispecifics were different.
Yeah, I think there's an entire session this afternoon.
Okay, I can wait.
But I'll just say that sequencing is what's going to matter. I think both of them are fantastic, and the majority of our patients are going to need all these therapies. So my plug there is I usually say if you can get both, and you're healthy enough to get both, get the CAR T first as of right now, and then the bispecific, unless we're using a bispecific for bridging that we talked about after we've collected your cells. Bispecifics are fantastic. They're amazing drugs, and they're off the shelf. But over time, you keep getting it, and so it can affect the T cells. So we talked about those exhausted T cells and using the same target versus not. All of that matters. So they're amazing. But yes, we talk about sequencing when we talk about bispecifics.
Okay, we had one question over here. We'll just go back and forth.
Hi, I had a question about the risk kind of categorization. If a patient was considered high risk from the first fish that they got from their first biopsy before they've ever gotten treated, and then they had their first line of treatment, and then it was 1Q gain in this particular sense, but then the 1Q gain is not there anymore. Is that significant in any way, or does it not matter?
Yeah, that's a great question. So the biology always matters. The problem is we don't know. We don't know the data in terms of, again, I think having things like HealthTree where all this data is collected and then we can look at those types of questions are important. So high risk definition did change recently, again, in like May or June.
Okay.
So 1Q by itself is not considered high risk anymore. And so you have to have one of the, so even 414, 1416, by themselves are not considered high risk. You have to have 1Q plus that,
Okay.
plus 414 or 1416, or two of them, or you have to have 1P and 1Q, or 17P even. We used to say, even if you had one cell that had 17P, we would call it high risk. Now 20% of your cells have to have 17P before we call it high risk. And why that happened is that all these places around the world actually looked at their big data sets. So you saw some of the studies that we talk about, right, with the newly diagnosed. Mm-hmm. Some of the studies we've done in the last 10 years, they looked at all those data sets to say, with our more modern new ways of treatment, who really is high risk? So with CD38s added to the induction treatment, that changes things. And so now we think of what we used to call ultra high risk. Those are our patients that are now high risk. So again, 1Q is not. Now your question comes up, what about these different clones, right? So we talk about clonal evolution, that more patients over time will get more clones in their myeloma. So they might not have any high risk features at the beginning, but after 3-4 lines of therapy, different resistant mechanisms pick up. And so now there might be myeloma clones that have some of these high-risk cytogenetics. I have seen it where someone had high risk and all of a sudden it's gone. Mm-hmm. And you're like, what does that mean? Testing can be an issue of what they had at the beginning versus now versus, I'm hoping one day that if we can get rid of the high-risk clones with things like bispecifics or CAR Ts and maybe an indolent clone that comes back, which I have seen in some of my patients who have gotten CAR T where the high-risk clone is gone and you're like, the disease acts more indolent where it used to act really high risk. So we're learning all of this right now. So I can't answer exactly why, but thankfully 1Q by itself is not high risk. But yes, we need to continue monitoring because things can change in those different clones of the different myeloma cells.
Got it. Thank you so much. That's great news about the 1Q gain.
Yes.
Oh, very sorry. Hi. I'm going to hand this, or I'm going to have my wife help me as well. She's got some great questions, and she's more on top of it.
And I don't really know how to describe the high risk factor. I'm reading FISH, deletion of chromosome 17 with loss of TP53.
Yep.
Okay.
So that's TP53.
Okay. And so he's, had a induction, auto stem cell, cilta-cell, CAR T, second stem cell. Anyway, it just keeps going on and on. And one of the things we're curious about is he doesn't have any BCMA. So that means CAR T is off the table from here on out.
Yeah, so again, coming back to resistance mechanisms, right? So you can have resistance with clonal evolution. So people that didn't have TP53 over time can get it. That makes it more aggressive. With immune therapies, our big resistance is either we've messed up the T cells over time, so they just can't work as well when we try another T cell, and why other treatments sometimes are really important, or your myeloma cells can learn how to get rid of those flags that we talked about. So BCMA is one. And so a lot of my patients who have TP53, where in your cells the DNA tells it to make that BCMA to go up on the myeloma cell is right next to 17, which is where TP53 is. It's chromosome 16. So if there's more cells losing 17, they can sometimes lose 16 too, and all of a sudden these cells don't make that BCMA anymore. Now, that doesn't mean the other targets are gone. So there are other targets that hopefully are still there that you can potentially go after. But yeah, that's one of the ways that with immune therapies, why do people relapse? And not everybody gets 5 years or longer, or even after 5 years. When people relapse early after cilta-cel or some of our bispecifics or CAR-Ts, it's usually because the myeloma learned how to get rid of that flag. There's a clone that just never had it, and that's the one that grew, right? And so then if that's what's growing, we know that another BCMA therapy is not going to actually get to it. So we have to figure out if there's another, either within the cell, like the other treatments that don't go after the flags, or if there's another flag that you can target instead. So something like talquetamab, for instance.
Okay, so one of the other targets is the GPRC5D. Okay, and so he's had Talvey.
Okay.
Okay, so does that mean all other bispecifics are off the table?
For right now, those are the only we have. Talvey is the only one we have for GPRC5D, and the other ones are all BCMA. But there's more that are, again, cevostamab is FcRH5, so a different target.
Okay.
That's been through phase 2 studies and hopefully will be approved in the next year or so. And then clinical trials, looking at things like other targets through clinical trials are really the other way to do it.
And of course, that's the other big thing is if you're non-secretory, which he is, then
clinical trials are hard.
Yeah, so we need some clinical. Are there any clinical trials for non-secretory?
I don't know. We don't right now at MD Anderson, because I looked, sometimes we do. So sometimes phase 1 studies will be able to do that. So the FDA requires us to do these things,
Sure.
but with phase 1 studies, sometimes we can say we're just going to use the bone marrow or the PET scan. So if someone has a PET scan disease or bone marrow disease, that we can use that. As of right now, for us, I know we don't, but there might be other centers that do. If I can think of something, I'll let you guys know. But
Okay.
I know it's hard. That one's really hard.
For now, the selinexor is doing.
I was going to say that's the other option.
That's where we're
that I
at.
think is really good.
Okay,
Thank
thank you.
you.
Yeah, of course.
Great. I have 2 questions. The first one is, do you have to have a transplant in your first line in order to qualify for this?
CAR-T.
For the
Or any
CAR-
of the other
yeah.
treatments? Yeah, no. So I used to be a transplanter, so that was my my COI. I switched over. So high-dose melphalan, it works amazingly, and it is one of the best options out there for the majority of our patients. But yes, a lot of my patients don't go to transplant because of some of the side effects they discuss and just for different reasons. But no, you don't have to have had that. You don't have to have a transplant to get any of these other options down the road.
And then the second question, if you also have had, during the time of your diagnosis, had another unrelated cancer, is there a period of time that you have to wait after that cancer has been treated before you can go to see
the
CAR?
next one. Yeah, it depends on the other cancer. So if it was prostate cancer or breast cancer, that was stage 1, 2, and we've treated it. For standard of care CAR-T, for instance, we usually say a year, and as long as there's no other disease. For people that have metastatic disease from solid tumors, or let's say a leukemia or MDS, that one's harder because if we do CAR-T, it does knock your immune system down. Part of that means that the other cancers could come back because we've knocked your immune system down, right? Or if during that CAR-T process, the first 3 to 6 months, people have low counts, and if we need to treat your other cancer with low counts, they might not be able to treat it. So it really comes down to that decision of how bad is it, what is it? Now in clinical trials, they'll say 2 to 5 years that it has to be in remission before you're allowed to go on a clinical trial, depending on what kind of cancer. Again, in the standard of care world, there's a little bit lax there. But again, if there's an active other cancer, that makes it a little bit harder to make sure that we can keep that other cancer treated as well. And MDS, so secondary cancers, is something we talk about with CAR-Ts as well, and with transplant, for instance. And so MDS, which is a pre-leukemia, we don't want to give somebody lymphodepletion chemo plus the CAR-T because that's probably going to cause much worsening of their MDS and leukemia. So those are patients that we actually say maybe a bispecific or something else is actually better.
Okay.
Okay, so I listened to your presentation earlier, and there were a couple things. One is the GPRC5D second-gen CAR T. Is that correct descriptor?
Yes.
Okay.
Yes.
If you could talk just a little bit more about that. And then also restaging risk. So since they've come out with new definitions for what's considered risk, because I was told when I first got diagnosed with MD Anderson 9 years ago that mine was high risk, and I can't remember. It's like a, anyway, it doesn't matter.
Yes.
So I wanted to know what you thought about that.
Sure. So with GPRC5D, there were a couple of different programs in the US, and it's down to one for different reasons. So it's the BMS GPRC5D CAR T. So they've done the phase 1 study, and again, those response rates of 91%, different doses. So when you do a phase 1 study, it's to figure out what dose of therapy we need to go to the bigger study for FDA approval, right, safety-wise, because no one's ever gotten this therapy before usually. So they used 3 different doses, and the toxicity that they saw with the higher doses without improved, so at 150 million doses, cells, they saw a great response rate of 90-something%. At the 300 and the 450, it was still close to 90% response rates, but they ended up getting another neurotoxicity. So we talk about neurotox as one of the things with our CAR Ts, with BCMA, right, cilta-cel. Here, they were seeing something called cerebellar symptoms. So it's the back of the head that we think that might have GPRC5D or something, we're not 100% sure, that can cause people to have balance issues and dizziness that can be really debilitating. So because the 150 million had less of that, much, much less, and had the same response rate, they decided to go with the 150. So right now it's in phase 2 study and a phase 3 study. So the phase 2 study at the 150 million, we've seen some good stuff. It hasn't come out yet, so I can't talk about it. But we still had some patients that had the ataxia. Now, I haven't seen it with any of my patients, but because that was a big enough issue that we don't want that to happen, now they're going to the 75 million dose. And so they're opening it up probably in the next month or so, where there's going to be 75 million cells. So a little bit lower dose of cells, but again, the response rates look the same. And so they're moving forward with that cohort on the CAR T study. So a lot of different centers have it. I think it's like 47 centers in the US and Japan, Australia, and Canada that will have that study open in the phase 3. So phase 3 studies, the problem there are that you get randomized. So in phase 1 and 2 studies, we know you're getting the drug, right? Phase 3 studies, patients get randomized to some kind of standard of care. So there's never any placebos, okay? So understand that. That never happens in our cancer trials, at least not in myeloma. And it shouldn't happen in any cancer studies, but you get a standard of care. So let's say anything else that's approved already that you haven't had before, or you get the investigational, so you get the CAR T. It's a 50-50 shot most of the time. So, because you have to compare it in real time at the, to show that, hey, this is better efficacy, but it's also not more toxic, right? You want safety and efficacy for that drug to say it's better than what we already have. So it makes it a little bit harder in the sense of, am I going to get the drug or not? But it's still important, and again, usually they do the phase 2 and the phase 3 right after, so that hopefully the phase 2 is to get the FDA approval. And so if you're on the phase 3, but we get the phase 2, at least the approval, all my patients who didn't get the drug, hopefully I'll have the drug to be able to give as a standard of care after. It was a lot harder when the first CAR Ts came out, because if they couldn't get it, we didn't have any other options. We didn't have bispecifics yet either. So today's world, again, the more options we have, we can give something else hopefully until it comes out. But sometimes it's a race for my patients who have really gone through everything already. And then your second question about risk. So yes. So again, that risk changes because of the drugs we have available, right? So some people who are high risk 10 years ago but never got an anti-CD38, technically you're not high risk because you've made it 10 years without it, right? So sometimes we put people in a bucket, and that's just the way we have, but their disease doesn't act that way. And again, if you had 17P with 1%, well, that might not have really been high risk that we didn't know about. So the French always use 60% as their cutoff, while everybody else used even 1 or 2% to say 17P was high risk. And again, looking at all our data together, we decided they were too much and we were too little. And so we came up with that 20%. So yes, risk can change. And the biggest thing that tells me is time. So if I put them in a high risk category, but they've done really well, over 2 years out and they're still doing well, then maybe they weren't necessarily high risk and that clone was something we either just saw by chance on the testing, or maybe it was a false positive, right? Every test we ever do, there's false positive, false negative, and it depends on how often they've seen it to really, every time I see a patient's bone marrow, if I see that same clone, then I know it's real. But if you just had one, that's a little bit harder to go by. So it just depends on your case. But yes, patients who do well, I can say you're high risk, and usually we try to do something different. So sometimes those things work, so that could also be why. But sometimes it's just that we put you in a box that, thankfully, your disease didn't act the way that we thought it was going to act, which I will always take that.
Okay, this may be a softball question here, but my cells are getting re-engineered right now.
Okay.
Within the next couple of weeks. I've got kappa light chain problems, so 41 was my number yesterday. After the 3 lines of chemo leading into the infusion, are they looking for a certain number on the kappa, a threshold number for that to be reduced to?
Yeah, there's not necessarily a number. What we say is from where you started before your bridging therapy to where you go in right before your LDC chemo, the 3 days of chemo, we want to see it the same or better, right? As long as it's the same or better, then it's usually good. Now, if you didn't have a lot of disease, so sometimes it comes back to this gentleman's question, if we go when you're barely going up, I know I don't need much bridging because you don't have a lot of myeloma already. So I've had some patients, very rarely, but I didn't, especially early line, when they go in second line, they're barely getting their myeloma up. The bone marrow has 5% myeloma, if that. There's no PET scan involvement. That I don't need to do bridging, and so then by the time they get to their cells, they're fine, right? But if you had a lot of myeloma, those are my patients that I need their kappa to get to low as possible before I go, because that's the disease that I'm worried about when there's a lot of volume of disease. So that kappa has to correlate to what volume that you have, so that's why.
There's not a lot of volume, but it's a painful volume
where
have.
It is, the location is bad, yeah.
Okay. Who else? We have time for maybe 1 or 2 more questions. Yeah, we've got like 5 more minutes.
Yeah, sorry.
Is it working? Do you hear me?
Here, I can.
No, you have to answer.
Well, I'll take it back from you. I'm okay sharing.
Thank you. I had IgA kappa in February 23, and in October 23, I had the melphalan with the B-sulfan. Both of them, and it was the most horrendous experience. Then in April, 6 months later, the cancer came back. So in August, I got CAR-T.
Okay.
And I have P53 positive, C1q, 1114, and 1416. I have all of them. Okay. All those, the nice, beautiful genes.
I know, all the ones you don't want. I know. Okay.
And but after the transplant, they put me on Dawa and Revlimid. And despite that, the cancer came back. Then I took the CAR-T. Now I am just on CAR-T, and so far okay. But the CAT scan and the PET scan shows persistent lesions in my 5th left rib, and the SUV, the standard unit something.
Okay.
The standard uptake value from the PET scan.
When did you get the CAR-T? How long ago was the CAR-T?
In August 24.
Okay, so not too far.
So, so it had been 1 year now.
2024. Okay.
It had been a year. Okay. But the CAT scan and PET was done in January and in April and another one in June. Okay. I still have lesion on my left hip and on my left 5th rib. And that was very painful. And after the CAR-T, they did some radiation therapy. But the subsequent imaging, these things still persist. So 2 questions. What are my chances of this being still cancer or just healing from the radiation therapy? And what's the chance if I develop MDS. What would be the treatment for that? Because I did not respond to Revlimid.
So yeah, great questions. I will say there's a lot more information I would need to officially tell you, but the fact that you don't have new lesions is a good sign. So anytime my patients get PET scans after CAR T, if their lesions are lighting up, the SUV is still a little bit there, part of it is I don't know if that's the new normal, depending on how high the SUVs are going. Early, at least in the first 6 months, we'll see the CAR T that are there. So you have something called pseudoprogression, that we'll see the SUV go up. Because again, these T cells are causing inflammation. So just like the myeloma makes the SUV go up, T cells can also make the SUV go up. And then radiation also causes more immune cells to go to that area. So we've seen that. If the SUV continues to increase, then I would say the best way to know is a biopsy. I try not to biopsy if we don't need to, but if you really wanted an answer if there's myeloma somewhere or not, biopsy is the way to officially say. Again, based on the fact there's not new lesions, that's a really good sign. But again, I think that's the only way you can truly say if this is active myeloma or not. And we've done that for some of my patients where they had persistent elevated SUVs that were clinically relevant. We went ahead and biopsied to make sure. In terms of MDS risk, so it's about 5 to 10% depending on late line versus early line. You had BuMel, so busulfan plus melphalan, which is also a little bit higher risk than melphalan by itself, because these treatments called alkylators, which was what the chemo for transplant is, we're just obliterating your bone marrow, right? Because we're trying to get every last myeloma cell, every blast myeloma, maybe precursor cell, but it also hits the other cells and the stem cells. So you have a risk of MDS. It's not crazy high, but it is high than a person who hasn't had a transplant at all, or or Revlimid, et cetera. I don't know 100% all the rest of your therapies, maybe 10, 15% chance of MDS down the road. Again, that's still lower compared to myeloma, right? Your biggest issue is the myeloma, and so just monitoring it the way they have been every 3 months is really important. And if you have myeloma proteins, the second that they start going up, that's when I'd say, okay, we really need to do something quickly, right? So coming back again to your discussion for your case with all those high-risk features, and you're relapsing within 6 months of transplant and an aggressive transplant, we want to make sure we act on something that's quick. Now again, so we had some high-risk patients on those studies where as long as their myeloma is controlled going in, they still did really well. If their T cells are really good, they still did really well. So I'm hoping that your CAR Ts still continue to take care of this, but it's just being hyper-vigilant. So I'm not a leukemia doctor. I will say I have patients who have MDS that they treat with usually azacitidine and some other, so they're not myeloma drugs. They're very different for leukemia drugs. And I do have a lot of patients with MDS that are getting treated for both. So they have some pretty impressive drugs on the leukemia side too, and they also have risk stratification. So they have high-risk MDS versus low-risk MDS. And most of my patients don't get Revlimid for MDS. It's not that kind.
One last question. They say if you fail the transplant within a year, 50% dead in 23 months. But before that,
That's before CAR T. We don't yet. I don't have those numbers. So this is what high risk. So when we talk about high risk, the definition is people who relapse within 2 years of transplant. That's where the original definition came for functional high risk. And so it used to be that we didn't have great options, and so patients died pretty early. So with CAR T, that's changed. We just don't have enough long-term data or enough patients that have gotten an early line. So a lot of these patients died before they could get fifth-line CAR T, right? Now that we have it early line, it's huge that we can actually do something different. And I have a lot of patients that we've given CAR T to, and they're at least a year out, doing really well still, but we just don't have longer follow-up yet. But I'm hopeful that this changes. And again, when it relapses, I'm hopeful that it's going to be hopefully less aggressive, but we'll have to watch it very closely.
Yeah, thank you. Okay, one last question, and then save your other questions.
Considering your T cells, if you've had a stem cell transplant, what's the kind of the recommended wait time? If
that's a great
it
question.
progressed and you needed to consider CAR T, do you kind of have an idea?
Yeah, so on clinical trials, there are the clinical trials I didn't talk about, but some KarMMa-2 and CARTO-2 and all the ones between 1 and 4, right? They actually looked at patients who just got a transplant and actually consolidating with CAR T if you didn't get a CR or a VGPR, right? So if you didn't get a good response after CAR T based on the myeloma proteins, you actually could get a CAR, after transplant, you could actually get a CAR T 3 to 6 months after that transplant. And we didn't have problems. It was only 30 patients or so for each of these trials, but 99% of patients we were able to make their CAR Ts for. So early line, I'm not as worried. Late line, when people get a second transplant, right, and then we're trying to make it, then I would say 3 to 6 months at least before. We have had a couple of manufacturing failures when patients just got that high-dose melphalan and just got their T cells infused, and within 3 months we tried to collect. And that's when it's later line transplant, that's when we see a lot more issues. Early line for most patients, if you wait 3 to 6 months, for most patients we can make it. But again, it depends on if you need it and your myeloma is that aggressive. Then we talk about risk-benefit of manufacturing failure and how far can we wait till we actually try.